Good morning. We're going to call this special meeting of the Health Committee to order at 10:30. And Victoria, would you give the invitation?
Please stand. Our Heavenly Father, we thank you for this beautiful day. After all that rain, we thank you for all the blessings that you bestow on us as a tribe and as people. And we ask for clear minds, open hearts, and may we do the best for all our Cherokees. Amen.
Shelley, would you roll call?
Yes, ma'am. Frankie Hargis.
Present.
Ryan Warner.
Honey.
Bill England.
Honey.
Keith Austin. Jack Baker.
Here.
Harley Buzzard.
Here.
Joe Bird. Sean Crittenden.
Honey.
Tom Garvin. Wanda Hatfield.
Honey.
Rex Jordan.
Here.
Dick Lay.
Honey.
Curtis Snell.
Here.
Denise Taylor. Here. David Thornton.
Honey.
Victoria Vesquez. David Watkins. We do have a forum.
Okay. We're going to move right into the subject at hand. That is new business, and it is a discussion regarding the Cherokee Nation Health System Provider Compensation Committee report. Who do we have here that's going to represent the committee? Just step forward and take a seat.
We have to introduce themselves. I'd like to know who they are.
If you want to come and take a seat also. Connie, would you come forward and make introductions real quick, please?
Thank you. We've been looking forward to the opportunity to present some work we've worked on for almost 2 years now with the help of our physicians. Dr. Lonnie Parrish is medical director of the Clinic in Bonita. Dr. Johnson Gord works at Three Rivers in Muskogee. Dr. Melissa Adams is a podiatrist. Dr. Thomas McKay, pediatrician over at Three Rivers. We also have Peter Brown, nurse practitioner at Three Rivers. Dr. Sharon Smallwood, medical director at Hastings Hospital. Dr. Katie Hughes, who's rocking it in our ER, by the way, right now, has our left about seen right down to that end. And Dr. Stahl comes in. I guess anyone think that's about it?
Okay, thank you. Okay. Would you guys like to make a statement before we move into questions, or? Okay.
Madam Chair. Madam Chairman, could I make a motion to put their letter into the record for Shelley? I'd like to put that in form of a motion.
Is it not in, it is in the book, so it would.
It's already in the
Yes.
book as a public record.
Yes.
Thank you.
Yes. What's last?
So, as a member of the compensation committee, as you all read in that letter, we were appointed by administration to be the voice of all of the providers, the physicians, the nurse practitioners, and the physician assistants in Cherokee Nation. We all feel deeply connected to Cherokee Nation. This is our heart, and this is where we want to be. And the whole reason we are here today is because we all feel very strongly, as you can see from all of the signatures that we got, that we are very committed to the future of Cherokee Nation. And we were just at our wits' end and very frustrated, and hopefully we can come up with a solution to keep all of our providers. And we are honored to be here today. Thank you all for having us.
I would just like to say that, one, thank you for allowing us the opportunity to appear. As she said, we are both part of the compensation committee, and we are here perhaps out of frustration, but not out of a vote of no confidence for our admin. We just feel like we need to show the support for them to allow them to have the tools. We are in the trenches day after day. We see the effects of recruiting and retention. We see the effects of not having enough providers, something that I grew up, having been born and raised in Tahlequah. I have seen this time after time. I am here not only because I'm a physician from the area, but I want to serve the people. This is where I grew up. This is where I want to be. And it gets harder and harder as healthcare in general gets more and more complex to keep physicians, to keep providers in general in the rural areas. Oklahoma, as you may know, is top 10 for physician shortages, for provider shortages. We only keep about half of our graduating medical residents, regardless of where they're at, whether they're the OSU or overall, the state only keeps half. So our pool to draw from is extremely small to begin with. It's a daunting task to recruit to rural areas regardless. Most of our clinics qualify for the underserved areas, so it allows some other special loan repayment. That's how hard it is to recruit. So we are here in support of health admin, not against. I'd like to make that clear. We would like for those that quote unquote hold the purse strings be aware of the needs that we have and give our administrators the opportunity to address those. And sometimes that, frankly, that just requires money, and we understand it's not always there. But we see that day-to-day need, and we see just the loss of one provider in a rural clinic can take months to a year or longer to replace. And that's a time frame where people lose out on services. So again, I would like to thank you for allowing us to appear.
Okay, we're going to move into questions. You want to go first?
Sure. And first of all, thank you, Frankie, for calling the meeting. I appreciate that. I think we needed it. Appreciate it. We've all read the letter, and we see, and I have been seeing more and more in my clinic, the retention loss of our docs and higher end medical staff. And it's you get a good one, you want to keep them. And so, I think this tells me where we need to at least start thinking about how to the retention to me is important. The recruitment obviously is important, but if we didn't lose them, we don't have to replace them to start with. And I think that's part of why you're here. And is that correct, or am I on the right track?
Yes, sir.
And I appreciate you all coming forward. I know that you worked on it for a while. How long did you work on this?
The actual letter?
Yeah, well, no, the program itself.
The compensation committee was started a little over a year ago. It has only changed one component. Only one person is not still on it. And we worked through various recognized data points kind of back and forth along with health admin. So it's been over a year.
And I appreciate everybody's work. I know it's more than just you two. We've got signatures from a lot of people all throughout the system and all the 8 clinics, including Hastings. And of course, my district also takes into Claremore Indian Hospital, which is not ours. But we see the problems everywhere. And to me, it's a retention thing. How do you keep them? And, when you get a good one, we don't want them to leave. And we keep talking about this probably monthly in our health committee meetings. And it's something that we don't forget and we don't lay down on, we don't let down on. These things happen, but is it all finances, or is it a better method of treating our docs, or what? Help me out.
Well, so, like Dr. Gord said, I was raised in Chicken Creek, so we grew up going to Hastings, and I know this is nothing new. It's not new, and I just know that the turnover is something that I've seen since I was a little girl going to Hastings. Every 4 years, you get a new doctor. I get it. So this is not just to keep physicians from leaving, but it's to we have to stop that trend. That's just the norm. And if you're okay with it, it's not going to get any better. But if we can do something to stop it, and yes, finances, yes, I agree. But a lot of it is also a broken process. I work on the weekends to make up some money. And I have no problem seeing 30 to 40 patients at that clinic. That doesn't happen in my clinic. It can't, because our processes are not in place to make that happen. So I think that it's money, it's compensation, but it's also a process that doesn't work. Would you agree?
I would agree, yes. We've expanded extremely rapidly, as everybody here is aware of, and we are continuing to expand. It's a complicated situation, and I do not pretend to understand how to fix it. I can just point out what I see from my perspective. And like her, having been born in Tahlequah, we too expected a new somebody, maybe even different provider every time we went, so it's not a new problem. Actually, you could call this maybe the pinnacle of my career, being able to present to you today my concern as a young man wanting to go to medical school and ultimately end back at either Hastings, or now they built the nice big clinic in Muskogee. But the opportunity to say, how do we fix this? This is why we need to fix it. We do not serve the people. The number one complaint I hear from patients is, how long are you going to be here? Or with the new ones is, so how long are you going to be here? And they're frankly surprised that I've been here for 5 years. So it is the process. We don't control all the variables. Again, this is not something that is new. This is not something that was changed in the last 4 or 5 years since I've been here. It's not a poor administration or a manner in which it's being administered. It is what it is, but it's difficult to navigate a clinic that is so large by virtue of the system that I don't have control day to day over staff or other things that would allow it to be efficient. Like she said, 10 years ago, I was seeing 30, give or take, a day in regular practice. That's not, it just doesn't happen that efficiently here. So there's other issues that we have concerning seeing patients. It's not just a numbers thing. It's not who can see the most, but it's the efficiency, and part of that has to do with turnover.
And can I just add that I have heard the providers don't work hard enough. They are lazy. That's implying that people who spent a lot of time going through a lot of extra years of schooling are innately lazy and don't want to work harder. That's not it. Like I said, we can see as many patients as we are expected to see within a process if the structure allows for it. So
I think it's a fair statement. The pool from which we attract applicants sometimes includes those who have no intention of staying longer than their payback. So in that sense, they are not vested. They are not from the system, and they may very well just be trying to ride out their 2 years or their 4 years, get their loans repaid, knowing that they're going to move on. And that may be where some of that comes from, because we've all had colleagues that we felt were just here because they were getting a paycheck and getting their loans repaid, and we would not see them in 2 years or 3 years.
Or locums that get paid by the hour.
Who do not
have no connections at
Right.
all. So, yes. Hopefully that answered.
Thank you.
Councilor Bozard?
Yeah, just a few comments, and something about deeply connected to the nation. To me, that means a lot. You get a doctor in here that's in California, he may not be connected here, but he came here for a reason. And for those reasons, to take care of patients. We're missing something because we can't retain that doctor. It seems to me like we're only retaining the people from this area. Now, just because you're from this area doesn't mean you shouldn't be paid as much as a person who works in Oklahoma City. You're taking care of our Cherokee people, and that's the main thing that we're here to talk about today. I don't know what kind of incentives you get. Do you even get any incentives?
We get an evaluation, a bonus that is tied to our evaluation every 6 months. And other than that,
There's the pay structure now, and health admin would probably be better to question about this, but the structure now has multiple aspects to it. Whether you're board certified, how many years of experience you have. So there's a base, and then there are other factors that add on to that base. Whether or not that's a good or a bad, it comes up to a certain number, and that certain number is lower the newer you are. So there's less of a draw. The starting salary, as you might expect, is a little lower than it would be for someone who's perhaps got their 10 years experience.
I also read that they were 25% lower in just about every.
Well, overall,
Yes.
and that too is, I think that is where there just needs to be a more dynamic health compensation committee that is able to address our changing needs. We change year to year, so from one year to another, this is not a stable salary. Our salaries have gone up in this way, and nurse practitioners, other providers, theirs has outpaced the physicians even. So it's a very it's very difficult to go, okay, well, here's a good salary and then stay there for several years, because it's constantly changing. It creates, well, we do good this year, but next year we're already behind the curve because they can recruit. They're already 10 or 15 or whatever the number is behind.
The other thing that concerns me is the frustration. I've heard that 2 or 3 times about frustrations. I know I was the director here at the Cherokee Nation for several years. And when I would have meetings, I would call all of my top people in and let them know what we were doing. It's a lot different from the medical field. I was in the roads program. We had engineers, we had designers and people like that were doing several different projects. And I just felt it was important to put all the people in one room and let people know what you're doing here and what you're doing there. Those communications meant more probably to those people that work for me than you'd ever know. They kept me informed and kept everybody in that loop of what we were doing there. Frustration, if you have that, you're not going to be too proactive. I heard you say you saw as many as 30 to 40 patients up where you work, and you said 30 something.
This is an outside system that's designed to allow. Yes, sir.
And now, I think from what I've been told, we see between 15 and 20 patients a day. Now, we have RNs to take care of the referrals, but how I understand the system works. You have an LPN that gets your rooms ready and stuff like this. So, seems to me like the system's there. What are we missing?
The implementation from the EHR system has slowed us down a lot. There's a lot of paperwork, and there's a lot of charting that you have to do. There's a lot.
I was going to get to that too.
There's a lot, and it's not as streamlined as when we did RPMS or other systems that I use at my other. And can I just add that I have gotten 3 raises from my other job, and I have gotten this many here in the last 5 years. So the process is just not there. I think a lot of it's the EHR system.
In the growth, there's some facilities that simply don't have enough exam rooms, or perhaps they don't. It's the system in general has just grown. So
well, only exam rooms. I want to say something about that, because we just built a new clinic in Jay, and we're supposed to have enough exam rooms. We have for 9 providers, they each have three exam rooms apiece. That moves people fairly quick through the system. I don't know about Redbird or some of the other clinics. Up there, that's what the problem was before. We didn't have enough exam rooms for our providers there, but that's been taken care of.
right. So
I have too, but then we have visiting specialists. We have the DM shoe, the diabetic shoe. They come in once a week, and then we have a visiting. Well, we have Dr. Burke. She's the podiatrist, and she comes in once a week. So they take exam rooms from us, and so I mean, my pediatrician right now, she's awesome, and she sees 20 to 22. She double and triple books herself, and she's working out of 2 rooms. So
it's a combination of all factors, sir. It's not.
Well, you know, I think, and I don't know if you know it or not, but I think most of the travelers were concerned about the new system we put in because it didn't work. It didn't work the way we thought it was going to work. So that can be a problem. I know some of the pharmacists have told me that now it takes a lot more steps than it used to take, and so it takes time.
clicking.
Click, 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 and then I stand at the J clinic when this woman is on there, it kicks it off because the system up there is not working. It's absolutely not working. The other thing that I've also heard is respect. respect from your people that are above you, people that work with you. It's just plain nothing but respect. Not any of this going in and yelling at providers, yelling at people that work there. Is that respect is being lost between some of our people. And I've heard this from a physician that actually told me this. I don't know what else they meant by it, but that's what they meant. They told me respect, respect, respect. So I just want to bring that up. The other thing with this, with RPMS, when we had that, it worked awful well because, and I know this is just minor stuff, we used to get telephone calls to all of our patients out there because you got an appointment tomorrow, you got an appointment the next day. Well, this $1 million system we got now doesn't work, doesn't do that. We have to take our administrative people up there and get on the phone, call, and that's how they get notified. Well, yeah, there is some frustration, probably not only you guys, but me too. So we want to hear more. What can we do to help? What can we do to fix it? Thank you. Thank you.
Counselor Taylor, did you have a question? Okay, I'm sorry.
Okay, Madam Chair, I have a request. I know that we can ask them to come back for more questions from everyone, but we might get some answers if we would allow health leadership to come forward and show us their plan of action, and then we can question after that. I respectfully ask that we do that.
Is that okay with the group? Okay.
Do they have this plan in writing that,
We could ask Dr. Stalka.
or Dr. Graham, just somebody?
Dr. Stalkup, do you have your presentation in print that we can also
Ma'am,
have?
I do not have a hard copy, I just have the electronic version.
Well, since we're at a break for questions, because no one else had to raise their hand, we're going to let you take a seat, and we're going to hear administration's presentation, and then we'll probably call you back. Okay?
Thank you.
We've actually been looking forward to some degree to being able to present some of this information to administration and the council. We've worked with our docs for the last year, as they spoke to, on what we need to do to retain our docs. And you could ask all 250 providers that we have, you would get 250 different ideas of what they want. And trying to narrow that down and be able to prepare something to present to both administration and the council, we developed the work group and selected respective members of our medical staff to represent each profession. For example, primary care representative, a surgeon. We had a PA representative, Amanda Oxford, who just came in, nurse practitioner, Kendra Round, and so they kind of represented each of their professions and what was important to them. Because we heard everything from a $25,000 a year adjustment to the base to more paid time off from the 6 weeks that they can ultimately work to memberships in the golf course, free tickets to the Joint, spa treatments. I mean, it was just all over, and and different health systems do that. I heard last week there's a health system in the Midwest relocating grandparents because this is a nationwide crisis with primary care. This is not unique to Cherokee Nation. It's not unique to the state of Oklahoma. And so that was why the work group was developed. And we've worked with them. And every month at this MEC meeting that we meet and we address credentialing issues, we talk about policies, challenges in the clinics, and we work towards solutions. This was put on as an agenda item. And so communication with the medical staff has been monthly for well over a year. We also have Amy Sams come and present the financial statement because I think a disconnect we had was them understanding we do have a budget to work under and this is the constraints we have. And so that's been very helpful, I think, in helping them understand you know, we have a budget to work under, and what can we do as medical staff to help leadership with getting the revenue in. So we have worked toward implementing what we call an RVU bonus structure. I'm not going to elaborate on that. I'm going to let Dr. Stahlcup present it because he has spent tons and tons of time. That is the model that Dr. Parrish spoke to when she works outside of our facility. It's a compensation based on performance, and I'll let you describe exactly how that looks. And just turn it over to Dr. Stahlcup with that.
Okay, so I'm going to take a few minutes to kind of go over this. I took over for Dr. Montgomery in July, and initially I said, let's just give an increase to base. So our last raise, we gave an increase to base salary. And right now, our providers average 11.5 patients per day. When we gave the increase to base salary last time, the thought would be that our providers would increase the amount of service to our patients, but for various factors that didn't happen. I think system design and things like that do play into it. So one of the tasks that I had was to find some self-funding ways of giving raises. That means issuing money to the providers that was mathematically tied to improved service to our patients, that was mathematically tied to increased revenue. With our current budget, we didn't have the luxury of being able to give a percentage increase to base salary without some form of guarantee that there would be increased revenue. So I'm going to go through some slides, and we'll project them up there on the screen. And I'm going to try to be brief with this presentation, but I think that this will kind of give you a better understanding of actually where we are as a system as we kind of work towards answers. So RVU compensation really is independent from base salary. So they're not mutually exclusive, right? There's no reason you can't pursue both. In fact, those are the three facets of just about every contract out there. What's the base salary? How much does it pay per RVU? And what level does the bonus start? And so I'm going to kind of go over these points. Okay, so right now, our providers are consistently below average in the amount of service provided to patients. Now, this doesn't mean that we have bad providers. It doesn't mean that we have lazy providers. It's the way we've kind of structured our system. The medical directors tell me that absenteeism is and unscheduled leave is a perpetual problem. We do see providers who have wide variations in the amount of service that they provide to patients. Some providers provide twice as much service as other providers in their clinic, yet they receive the same compensation. Because of that, we've come up with a staffing model that is so costly that adding provider positions becomes very difficult, not only to pay for, but to determine how best to scale your system up as we're doing these expansions. And so our current incentives, you're going to see some orange ones and some purple ones up there. The orange ones don't result in decreased patient service, and the purple ones do result in decreased patient service, decreased appointments. But what we don't have is we don't have any incentive that rewards a provider for providing more service or for going above and beyond. And this lack of a positive incentive has resulted in some numerical kind of underperformance in our system. Once again, it doesn't mean the doctors are bad. It just means that we have some problems to fix. So RVU stands for Relative Value Unit, and here's how I think about it. It's the most accurate measure of the work a provider does, and it's the most accurate measure of service to our patients. So if one provider does 5 RVUs and another provider does 10 RVUs, the provider that did 10 RVUs provided twice the level of service to patients. Okay? We used to count patients, but counting patients doesn't work because an ear infection I can see in about 3 minutes, but an elder who comes in with 5 different medical issues may take, 30 or 45 minutes. And so when we just counted patients, what we found was there wasn't really an incentive to take on the more complex patients. Maybe an elder walked in and said, I don't have an appointment, but I feel really sick. We want to reward the providers if they want to go above and beyond and provide that additional service. So an RVU bonus payment is funding, and I won't get too bogged down, but basically in primary care, for every RVU we deliver, we get $120. Our cost in the salary and fringe for that provider averages $64.45, okay? Now that $64.45 number is a little bit high because we have some providers who are delivering very few RVUs. And so basically every patient that gets seen, or every RVU that's delivered to a patient, we have a positive balance of $54, okay, between what we're paying the provider and what we collect for the RVU. But now this is an average. What we find is we do have providers that, not counting all the nursing costs, not counting the electricity, not counting all the facilities fees, the providers actually lose us money because the salary and fringe is higher than the collections per RVU. So this is the most important graph in the presentation. And I'm going to draw your attention to this green line. Now this green line is the average performance in primary care of a system in our region. This red line is where we are performing. So we have the facilities and the staff and the doctors and the nurses, and everybody is already paid, but yet we're losing about a third of our service. Another way to say that is we could serve an additional 35% of patients. So of your constituents who can't get appointments, this is the reason. When you hear that people are on waiting lists for various things, this is the reason right here, is this 1/3 underperformance when compared to facilities that have same staff. So right now, our current primary care production follows this blue line. And as we said, $119 collected per RVU, $64 paid, okay? So if we told our providers, hey, if you can do above our average, now not above the average of other systems beside us, that's a lofty goal, but if you can do above this average, then we'll pay you $40 for every RVU that you generate. So what would happen is if we had providers that could reach the average of the real world, let's say, and this is called the MGMA regional median, if we had providers that could reach that average, we could pay them a $16,800 bonus every quarter. Now, we'd still collect $119 per RVU, and we'd pay out $56 per RVU. So now our cost per RVU has gone down, and we have a positive balance of $63. This is money that we can use to provide larger base salaries, provide more services to our patients. And if we had providers that performed above average, we would actually lower our cost per RVU down to $53, even when we took into account an almost $27,000 bonus every quarter. And y'all have heard me talking here about my expectations of what we should do for people and the level of service that we should provide. And I don't think that shooting for the average is setting our sights too high. I think that we can, as a system, achieve an average level of service to our patients. And we'll show you what that would do to revenue, and it would have a really phenomenal impact, not only to the revenue side, but also to patients' lives, being able to get treated when they needed treatment. Okay, so there's a few attributes to RVUs that I want to talk about. They are self-funded. They can be used to encourage management of nurse practitioners and PAs for the providers. That's something I think is very important. It results in more patients being cared for, but the main advantage to us is I think that this is the only means of solving some of the problems that we have. Some of our service lines that have low production and some of the absenteeism. And I think that Dr. Gord made a great point in that, you know, it takes a system that supports this. And our docs on the front lines are the best problem solvers there are. And so I believe that the reason the reason that we're below average is because the average is RVU-based compensation. So that's a strike kind of we've got going against us, is they actually incentivize more service to the patients. And so if we can get the docs incentivized to serve more patients, then you have some of the most intelligent problem solvers in your organization actively working to figure out how we can solve the problems. Instead of, having, it doesn't work to have management walk into a clinic and try to figure out how to solve the problems. We need the people on the front line engaged in solving that. And so what we see is we do have some providers that actively try to solve this, and those providers are very productive. And we have other providers that kind of make rules about, well, don't schedule me this patient, and don't give me a walk-in after 2 p.m., and don't do this, and they make these unofficial rules, and those providers aren't really engaged in solving it. Those aren't bad providers. We have a organizational workplace culture that is in place, and it's fairly common in certain areas that pay a flat salary. Some other tribal systems in the VA do have this, and I believe that leads to a lower, I think it lowers the patient experience, and it leads to a lower level of service. Okay, so these are the facts of how much our different service lines produce by specialty. So our nurse practitioners do an excellent job in urgent care. They are 130% of the average, so they're above average. And our nurse practitioners in primary care and our PAs in primary care both are about average. Our nurse practitioners in pediatrics are a little bit lower. Now, there's some reasons that our nurse practitioners do very well. One of the reasons is they see very complex patients, okay? Our nurse practitioners in many instances are used interchangeably, and that's not a perfect word, but interchangeably with some of the physician providers, and so they see very complicated patients that generate a lot of RVUs. But here's where our costs go. So our emergency room is 21% below average. Our urgent care is about 26% below average. Primary care, this is a big one. We are a full 35% below the RVU output that we should be at. And so this is when we come to health committee and we hear you talk about, this person can't get a primary care doc, this person can't get in when they're sick. This is one of the main drivers of that. Our outpatient pediatrics is fairly comparable to primary care. There are some inordinate costs with general surgery. Our general surgery department puts out about 50% of the RVUs that could be done with our staffing in our facilities. These, to me, are the problems that are going to keep us from truly reaching the next level, both in compensation to our providers and in service to our patients. And I am worried that we won't solve this problem, and we will open a new facility, and there will continue to be scheduling difficulties and wait lists, and we will wonder where we went wrong. And I think that we will probably determine that we did not have the correct incentives in place. And so that's why I would like to solve this now. This is one of the things that I would like to solve for us. I would take issue with any provider who argued that we are unable to achieve average. I think average is reasonable. Okay, so let's go over some high points. So if we had physicians in primary care that increased to the average, they would get a $67,000 annual bonus. It would increase our positive financial balance per RVU by 12.5%. So I know that a lot of y'all have businesses, and anytime you could increase a positive financial balance by 12.5% per transaction, that's an incredible gain. The revenue gains look like this. So in surgery, we could pick up almost $2 million a year if we could increase to average. And that's interesting because in surgery, the payer mix is a lot of folks are self-insured, right? And so even though we have a lot of non-payments in our surgery patients, we could still pick up the balance just through the volume, just through what we do collect. Primary care, this is another big opportunity. It's almost $4 million. And so this is a sizable increase, but I don't want to focus on the money because this is something that you could fill football stadiums with all the extra patients that were served that year. So the money's one thing, but I like to visualize all the extra patients that are served, patients who need to be served now. Okay, so this is a chart, and I'm going to walk you through this. Don't get overwhelmed by the numbers, but I'm going to show you this is what absolutely this is the source of negative impact to patient care, and this is what leads to unsustainable scaling, and this is what leads to chronic underperformance. So these are two doctors, okay? You'll notice this doctor got paid $10,000 more than this doctor, okay? This doctor got $73,000 in 3 months, and this doctor got $63,000. The period that this was run for, this doctor was eligible for a bonus, and this doctor wasn't, so that accounts for the difference. So they are essentially making the same, okay? So collections per RVU. This doctor collected $101 per RVU. The system collected $101 per RVU for the care that that doctor delivered. The system collected $74 per RVU for the care that that doctor delivered. So what does that tell us? That tells us nothing, because these doctors are at two different clinics, and two different clinics have two different payer mixes, okay? But here is the frightening part. This doctor, we paid this doctor in salary and fringe benefits $72 per every RVU they generated. We paid this doctor $136. This doctor generated 1,000 RVUs. This doctor generated 460. So this doctor served more than twice as many patients during this quarter. Yet the compensation is roughly the same. So every patient that this doctor saw, we lost $35 in compensation, just in the provider's compensation, not counting all the staff dollars that it takes to support that doctor. So this is what we need to repair. Okay, so I always like it when somebody says what outcomes they're looking for. I don't like nebulous kind of, well, our goals are this. What I'm looking for is I want to increase the amount of patients we serve to the average. I want there to be no more wait lists. I want to drive down the cost of care. I want to improve recruitment. I want doctors to not use inappropriate sick leave. We certainly want them to use sick leave when they're sick, but we have doctors in our system that rarely get over 8 hours of sick leave accrued. I want to provide an incentive for moonlighting. So we have, like Dr. Parrish said, I mean, Dr. Parrish is an extremely gifted physician in my opinion. So we lose her labor to outside sources that pay her. With an RVU-based system, you can add additional incentives for people to moonlight within our own system. So they could pick up urgent care shifts. They might pick up an extra shift at a clinic. I think that us retaining our own doctors instead of having to hire contract doctors like locums would really be beneficial to our system. So I like the double dipping, so to speak, if we could provide a doc with an hourly rate for extra work, but then also say, hey, and you can keep your RVU bonus for that time. Eliminate unsigned notes. We have terrible problems with unsigned notes. Had a medical director brought to my attention the other day, had hundreds of incomplete notes at a facility. So this is a patient safety issue, right? We don't want there to be a time that patients come in and get seen by doctors and then prescribe medicine, but the doctor doesn't type out what happened during that visit. And so the good thing about unsigned notes is an unsigned note does not generate any RVUs. So the day after you go to an RVU system, the doctors start completing all their notes. And then we talked about creating problem solvers on the front line. I think that this is going to be how we get our system more efficient. And another thing I want to talk about is choosing Cherokee. So we say we want folks to choose Cherokee. We want to compete with everyone out there in the private sector. Well, the fact is, you can't compete if you have wait lists. You can't compete if you can't offer visits. You can't compete unless the patient says, I would like to be seen this morning, and you say, yes, we'll be happy to see you. What time would you like to be seen? And then I want to provide a positive environment for the JV expansion. This is a big one for me because I think that when you have an inefficient system and then suddenly you make that system much larger, but you keep those inefficiencies, it's going to lead to downstream problems that we can't even predict. And do RVU contracts work? So virtually all of our competitors use RVU contracts. 72% of all contracts in America are RVU. If you look at it specifically by profession, like family practice, it's probably 90 or so percent. Some service lines don't respond to RVUs as well. And this is kind of interesting to me. So within our own system, our Cherokee Health Partners has cardiologists, right? And those cardiologists consistently performed 130% of the MGMA average. And the reason was Cherokee Health Partners, which is Cherokee Business, provides healthcare to our citizens, uses RVU bonuses. And so those cardiologists were very much in tune with how many patients am I serving? Can I see an extra patient today? Can I go above and beyond? They would get called in to see a patient. In the back of their mind was, hey, I'm going to increase my RVU number. You know, this is how people respond to incentives. So I think it's kind of interesting that in one area we have this chronic sort of underperformance, and yet in another area we have chronic overperformance, and the only difference that we can discern between those two is the way we issue contracts. And these are some mechanics. Typically, you know, there's a number between about $30 and $45 paid out per RVU over a reasonable goal. You want the bonus level to be reasonable because we want people getting bonuses. The best way to get people on board is to get them getting bonuses. So we don't want to set a bonus level at something that's unachievable. And we would issue contracts for 1 year because nationally the averages change. Okay, and this is a graphic here that shows how much it would cost in bonuses. And now don't get confused by these numbers. Let me walk you through this. So if we set a bonus level at a reasonable level, some folks are already above that level, right? So we're going to have to pay out bonuses to those folks. So right now in primary care, and the top line is primary care physicians, I'm going to focus on that. So if we paid out a bonus at our current average of RVUs, and remember that's about 35% under the regional average, 10 of 21 doctors would get that bonus, right? Which makes sense, about half of them are above average in production, and that would cost about $355,000, okay? Now, that would cost $355,000 for all specialties if we totaled them all up. But I'm just going to focus on family practice because this will give you an idea. So if we set the goal at the 25th percentile, now here's what I mean by 25th percentile. I mean if you take 100 systems and you look at the bottom 25, if we said we want to set it at that line, only 4 of our primary care physicians are above the 25th percentile. But 20 of 21 of our nurse practitioners are. And so that would lower the cost, but not tremendously. It would drop it to $324,000. And if you want to get to the 50th percentile, which is where the average is, first you got to figure out how to get people to the 25th percentile. You know, we want to make sure that these 17 people who can't get to the 25th percentile, how do we bring them along and get them there? And if we paid out a bonus at the MGMA median, this is the average, okay, this is where we want to get. We want to get to the average of systems our size. Only 1 of our doctors currently achieves average, and about half of our nurse practitioners. And this would lower the cost down, and y'all forgive me the mouse pointers on that, but I think it lowers it down to somewhere around $150,000 if we took that route. This level is too high, I believe, because I don't think that you put in a bonus structure that very few people can achieve. You know, I think it would be better off to be somewhere in this area, and in about 8 hours I can mock up the appropriate level for every specialty. Okay, and that is all the slides that I have, and I'll be happy to answer any questions.
Okay, do we have any questions? Counselor Crittenden?
I'd just like to hear from the docs, kind of, not necessarily a rebuttal, if you will, a rebuttal. Just what's your thoughts on this?
So the RVU structure, as far as I know, is not used in any other government system because it assumes that these patients have a payer source and that they're not Medicare or Medicaid. So I And just to clarify, my outside job that I work, you know, I see 30 to 40, I don't get paid RVUs because I'm not a full-time employee. I get per shift, and I still am able to do that. So there are issues with the limit that we can see. We would see them if we can, obviously I do, and I would. But the RVU, the compensation committee, we wanted base raises first. And if you all, I have a contract from the Osage where they offered a whole lot more and their benefits are even better. So, and they see the same amount of patients we see. We need the base first, and we said we would entertain this later because, like Connie said in her email to us, that the RVUs are just now reliable. We don't already have a lot of confidence, so how are we going to be on board with this now when it's just now reliable? I know our coder, Melissa, if you want to jump in.
Just information is trying to check the values. With the hospital itself, I'm not speaking for outpatient, I do inpatient and outpatient. Just inpatient itself, right now, there's over 400 short having been included. And that's from all payer sources in 2017. There's still some from 2016 that aren't coded yet. So one of the concerns with this is when we're looking at the numbers and saying, well, this is where we are with the RVUs, well, there's still a lot of lag in here that hasn't been given. Additionally, with the concern that these codes aren't actually up to date, that we're lacking on having this in an up-to-date fashion from 2017 to now. And that's not me speaking on the clinic side, that's just hospital, which that will hit us as surgeons, general surgery, orthopedics, podiatry, those of us that are actually performing surgeries. When you're looking at our numbers of RVUs, part of our time is actually spent in the hospital doing inpatient things. So if there's codes that are an inpatient side, then you're missing part of our values also.
Dr. Stolick.
So these RVU numbers have been run and validated. They were for September, October, November. In anticipation of this, I worked with Mitch Thornbrew, and he's gotten the coders down to a consistent 13-day backlog that he can deliver on. Dr. Adams makes a good point. You have to have everything coded so that you can make sure that you're actually paying out bonuses correctly. You wouldn't want a coding backlog. That is terrible. So in these numbers, every visit that generates value or service to our patients has been coded correctly and validated. And we do quarterly third-party audits to ensure that those are being coded correctly.
Any other questions? Janice?
Is healthcare administration prepared to implement this system?
With the approval of the administration and the council, we feel like the RVU bonus thing would be a great place to start to improve the compensation of our providers and increase access to our patients. I can't imagine the impact of a 30% improvement on access.
Well, I think
Improves
everybody at
quality.
this table wants our patients to be seen,
Yes.
because, I mean, that's one of the main calls we get is, I can't get an appointment. So, I mean,
I think that Dr.
It's
Parrish
all
makes an excellent point that government systems don't use these RVUs. And so every time you see on TV a problem with wait lists or people not getting surgery on time, it's always in a system that doesn't use RVUs. So the VA, other tribal systems, and I speak for myself, I don't speak for Ms. Davis or anything. I don't want to compete with those systems. I want to be far better than those systems. And so that's why I want to mimic the best that people can do in the private sector, the best that people can do. You know, this is who we compete with. Whether we want to acknowledge it or not, we're competing for patients, you know, to serve patients with people in the private sector. They have clinics in the same towns that we have clinics.
Vasquez?
Yes, how long would it take to implement the system?
I would say that we could probably have all the structure in place in 60 days. Now, the bonuses would be quarterly, and the quarterly bonus would be paid out 6 weeks after the end of the quarter. And so we want to get providers raises ASAP. Now, the good news is we can do this retrospectively. We're collecting all the data now, so we can pick a quarter, and I would like it to coincide with our fiscal year, but we can pick a quarter and then bonus based off that quarter. And the cost retrospectively would mirror the cost you saw on that slide. So if we bonused at the 25th percentile, let's say, it would be about $350,000. It's interesting to note that one of our big competitors is a local facility, and that local facility bonuses at the 75th percentile, right? 25% above average, and they pay out bonuses every quarter. So I think that, as time goes on, we could see that performance increase.
Councilor Byrd?
I think Councilor Lay had a question. I'll go after him.
Thank you, sir. Thank you, Madam Chairman. Doc, a couple of years ago, I went through, I think it might have been a work group or it might have been a full committee. I think your predecessor was still on. And we talked about a lot of this that you're talking about today. I don't think RVUs were mentioned at that time.
The technology was not in place. You're absolutely right.
But it kind of sort of sounds like where we're going here. And we all want people served, and we want to do it, I hate to say this as cheaply as possible, but that's what you're looking for in this system, I think. But I remember the talk that I got then, that we got then, was if we can just get this EHR system in place, it will solve this problem that you're talking about on your screen here. It didn't solve it.
No, sir, it did not.
Now we're going to plan, which plan is this, B, C? I'm not sure.
So I will say that nationally, one of the more commonly touted selling points of the EHR is that it increases patients seen. Well, having practiced personally on 5 different EHRs, I will tell you that they've all got good and bad things about them, but I ain't seen any that are really fast. The EHR has some benefit to it. It has a lot of benefit. The database of RPMS was becoming unmanageable. That was a very big concern of mine. I remember staying up late one night because we had all the patient records down on one hard drive, and I was like, how many times do those bearings spin? What if that bearing goes out? I have a bearing go out in the truck. So that had me nervous. I think that there are some systemic sort of values to the EHR system, some of the analytics that we're starting on now and things like that. The fact that this is built into the EHR system actually is probably the most advantageous part about it, because now we can actually get a snapshot of how our doctors are doing. And I know that, like Dr. Parrish is a medical director, I was a medical director, that counting patients really can be difficult. It's difficult to figure out the actual level of service that's provided, because what happens is, and I'm not immune to it myself, 4 o'clock, I'm ready to kind of wind the day up and say, well, I got an hour left. Dr. Stalkup, somebody just walked in. What is it? It's a kid with an ear infection. Okay, bring him back. Oh, actually, another somebody just walked in. What is it? 75-year-old female, congestive heart failure and diabetes and COPD, and she's gained 8 pounds in the past week and can't breathe. Well, that one may need to go to the ER. That's not what we want. We want somebody saying, hey, let's bring them all back and let's serve as many as we can.
Well, that's what I'm getting at, I think, in a roundabout fashion, perhaps, is we were promised that this system by now would be running down the road. We'd all be so happy we wouldn't know what to do. It didn't happen. I was told that software package was going to be about 1/3 of what it ended up being. And I'm not going to mention numbers because I've been told not to. But how much does this cost?
So this is already included. We already have this. It's already up and running. It doesn't require any upgrades.
Have we already purchased it then?
Yes, sir. It's already in the domain. It's already active and validated.
I'm not going to ask you how much it was because
It was actually the only thing that was included. Sorry, I apologize.
We went from 10 to, well, never mind. But anyway, my previous life, I worked with a lot of engineers, and I've seen a lot of graphs like this, and the numbers, trust me, never pan out. You know, say your car can do 120, it can't. It can do 111, maybe. It can't get to that 120. So that still won't be a failure, I don't think, in your mind.
No, sir, I
You
don't.
can get to 70 or 80, but I'd like to hear from the docs behind you what they think of this plan.
Yeah, absolutely. Madam
Let's-
Chair, do we need to?
Let's go ahead and see if we have more questions.
We got
others.
2 more
Um,
counselors here.
Counselor Warner?
Thank you. Obviously, I think my number one, without a doubt, is care for our people within logical reason. And I know everybody here, that's all I've heard is care for our people. That's a very logical thought. I'm reminded of when Cherokee Nation made a change in the dental process. We went from doing it the way we had to a more of a private way. And I'm also reminded of that bottom line, you know, making 500,000 to 5 million. Not to say that this is the same issue and can be solved the same way. My major, you know, I know to me when I was a kid growing up, a bonus was Papaw giving me $5 so I could go get a Frito chili pie. And I was glad to have that bonus. So a bonus is, I mean, when I see something like this, if it works, you know, 75% of the level that it can, I'm ready to go back to med school. You know, I mean, that's where I'm at. But also, you know, I'm very conscientious of what the doctors are feeling and what they are. We mentioned this RVU. If you guys want to implement it first, they want the base salary pay. If we did this first, when could we consider something to the base?
So, you know, I'll tell you this. I believe that we are going to have to increase our base salary. I'm not arguing against that at all. I mean, this is going to have to be done. Even if all of our docs said, we're dying to have RVUs, we're perfectly happy with this, that really doesn't let us plan for the future because we've got to be competitive in the overall marketplace. I think that in the first quarter, after implementing this, we're going to see a revenue jump that is sufficient to provide all of the base salary increase that we need. Right now, without some sort of cuts that result in more available funds, I don't know how we would pursue it.
Right. Okay. Well,
But I would be ready to reconsider the moment we see the needle move on the revenue.
right. Well, that's what I like. You know, and I hear too that we have a process problem. You know, and I mean, and I'm too. I mean, we've thrown money at this process problem in the past, and it hasn't fixed the problem. You know, but I also know what it's like to have added duty without added pay.
Mhm.
You know what I mean? So I'm just very mindful of those things where I'm at. So if, you know, I'm all for doing something, you know, and I mean, I like what this says. I'm also with Counselor Lay. There's things that don't always work out the way it's supposed to. But, you know, the bonus level, I like that. It seems reasonable. You know, to not expect them to go, hey, you're going to have to get prepared.
We don't want to do
run
that.
up to this level. But I do like that progression because the care for, I want to tell you, the bottom line my elders will have at home is that the fact that they got an appointment in, you know. But also, I want them to go see a healthy-minded doc that feels good about where they're at and where they're working. So if we can come together and take all those things into consideration, I'm on board. Thank you.
Counselor Crittenton?
So pardon me for not knowing this, but the docs dressed in the military uniforms, does that apply here?
Commissioned officers.
Mission Corps.
Does that apply here?
So that would not.
Okay, I've got a really, really close relative, I don't want to say even his name, loves the doctor he sees, and it's one of the commissioned. And she is considering other options, and this relative of mine loves this lady. And is there any way to to keep these two?
So there are methods of increasing commission core salary. They're a little bit complicated. I don't have a good grasp on those, but we want to make sure that we provide everyone. We would extend this obviously to commission core if we were able to, but unfortunately we're not able to.
And
We
the
can't.
IPA employees would be the others. This would apply to Cherokee Nation employees.
Right. And these others, they wanted me to ask, are there plans to essentially give them raises?
I would say that right now, yes, there is a method for doing this, and I talked with Admiral Grimm about this. Like I say, we certainly intend to try to bring everyone along compensation-wise, but I'd rather have him speak to that, Counselor, so that I don't.
I didn't want to get off point, but regardless of.
There are team members too, yes, sir.
They are
Yes, sir.
serving our people.
Absolutely.
Well, as I hear. And also, the green line and the red line, while we're all here, I wanted to give someone the opportunity, it looks easy. Hey, let's go to the green line. But I want to give these folks a chance. What problems do you see getting from the red line to the green line?
With the RVU.
Yes, what we.
So, Dr. Adam, everybody can help me if you want to, but we have a lot of patients who don't have insurance, and we have a lot of Medicaid and Medicare. And so, it's my understanding, and I've never been paid RVUs, to be honest with you. So, I don't exactly understand all the inner workings and the p-values and all that stuff, but I know that how are we expected to pay our providers money when you didn't collect anything from that?
Okay, so this is a good point. I overlooked this in my presentation, so good. That's a good point. So uninsured patients still generate RVUs. RVUs are based on the amount of service provided, whether the patient has a payer source or not. And so when you saw that slide that said the average collection is $119, that's actually from Amy Sam's analysis of the overall payer mix. So that includes the uninsured patients, the Medicaid, the Medicare, and the private insurance. So that's a great point. When you calculate those numbers, you have to take into account the entirety of your payer mix. But if I'm a doc and let's say I'm in one clinic and 50% of my patients don't have insurance, or I'm a doc in another clinic and only 30% don't have insurance, that does not affect the RVUs that I generate. And one of the big issues that we had with this coding revamp that we've done, and I wish Mitch was here to take credit because he's done a wonderful job, is a lot of the uninsured office visits were kind of put on the back burner, right? Because we're not balance billing our patients. Why do we need to process those? Well, what we found in the initial review of the RVU documents where we were missing those. And so now, in preparation for y'all's decision, whichever way it is, coding actually codes those uninsured visits at the exact same rate that they do the insured visits. But that's a great point that Dr. Parrish made.
Is that all, Counselor Crinton?
Yeah. So ideally, we're talking about, we're going to visit the base pay, right? We're going to visit that idea. And this is not my level of expertise, I'll tell you. But seeing it presented, I would be curious, if we're going to talk about base pay later, is it something you guys would like to try?
We can't talk about base rates later. I'm going to be honest with you, and I think I share.
Okay, I think we need to stop it there. Let's go on with the questions of Dr. Stockup's presentation, and Dr. Gordon will come back up afterwards.
Sorry.
Counselor Austin, did you have a question?
Yeah, all of our talk has been about the providers. We have many employees who are underneath.
Yes, sir.
And I don't think any of those are overly compensated either. Tell me if the RVU system benefits the rank and file folks.
So I will tell you this. That's another great point. So what we want to do is we want to establish a structure that rewards everyone on the team. I mean, I'm talking about the folks who check the patients into the clinic, the nurse that takes care of them, things like this. We may find that it's more efficient for us to have scribes in our clinic so that the docs aren't having to interact with the EHR the whole time. And we believe this is going to give us leverage to install more bonus systems for these other positions. I think that this has been something that I've kind of worked on and done a lot of brainstorming on. The key piece of the puzzle is to first get the providers engaged with the RVU system, because that is going to give us a litmus test on the impact on revenue, and then that will let us kind of go forward with those funds to start engaging other members of the team with bonus structures. But what you described is actually what my vision would be, that everyone who goes above and beyond is rewarded for that.
When you implement something of this model, we can attract people who have a better payer source, who have those insurance providers. And that will bring more cash into our system and allow us to do those kinds of things. We recognize that these docs are going to be dependent on the clerk at the door. Because if they're not motivated to stay another 5 minutes and see a patient and finish up with their appointment at the end of that visit, then it's going to impact those. And so we're prepared to implement something that also benefits the staff in between. We want our patients seen. I want everyone that presents to be seen. I don't think there's anyone in this room that doesn't want the same thing. But we can't take a big jump and, devastate our health system revenue and our finances in doing so. We've got to take steps and be very cautious on how we do it, but keep our good docs and let them know we appreciate what they do at the same time.
I'd like to come back here and, and this is one of the reasons I do this. I want to come back here in about 2 years and we all just kind of laugh and say, remember when we used to talk about wait lists? Because there are none. Remember when we used to talk about people can't get an appointment? It doesn't happen anymore. That's what I would like to see.
Well, in the 90s, I was a medical equipment sales rep for 5 years, and then was regional manager for 5 years. And our whole system of compensation was built off of performance. But the key was that I wasn't only, because I performed very well in that system, I wasn't the only one getting the compensation. Those who were part of the team that made me successful all were getting compensation as well. So if they were anxious for me to get a big bonus, because that meant they got a bonus. And everybody in that system was able to have a more Merry Christmas because I had sold more than the guy beside me. So that's why I was asking that question. A question I have is, are our doctors or our providers, do they know what the funding source for that particular patient is?
So I would say that for the most part, no. Now, sometimes they do. Like if I'm going to refer a patient for a service, I might say, now, do you have private insurance or do you have Medicaid? That can help with contract health. But for the most part, our providers have no knowledge of what the payer source is.
And I wouldn't think that should come into decision-making in who are we taking care of and how are we taking care of them. Maybe it comes into how we can take care of them in the contract health field, but not within our facilities.
And so one of the interesting things about RVUs, one of the things I like about it is in the private world, there were physician-owned practices at one time, like a long time ago. Now it's like less than 2% are physician-owned. There used to be physician-owned practices, right? And so there would be or there was always the potential for, who's got what insurance and what procedures can be done and things like that. The beauty of RVUs is, I can have an elder who has no payer source, or I can have somebody who maybe is out of work and doesn't have, just lost their insurance, and I can still deliver top-notch intensive management of that person, and I can still benefit as a provider from the RVUs of that visit, even if they don't have any insurance. So it doesn't result in any kind of preferential.
But I wanted to make sure that it didn't punish the doctor or the provider if that patient didn't have funding source.
Right, absolutely not. Absolutely not.
Because they're taking care of our people.
Yes, sir. Yes, sir.
Councilor England?
Thank you, Madam Chair. And Dr. Stockup, I appreciate your presentation today and everything. My only thing is, I've sat here for many years, and, you know, we go through these new things all the time, and then we're gonna implement them, and it just seems like they crash in the end, and nothing ever happened. My primary thing is, I wanna look out for these people, just like I would've looked out for you when you was in nowhere, you know, but these people sitting here, I wanna see this happen as quickly as possible without a lot of red tape. Because I too, like somebody said earlier, these other tribes are scooping up our people. The Osages over in our area over there, I mean, they're getting, you know, they're making offers to our providers. I know what a clinic is basically an empty nester up there, you know, and they've not done anything about it. I mean, and you've tried. But if it's the money part, then we sitting at this table need to figure out where the money is, and we need to start providing the money so you can pay these people to stay at our house.
Absolutely, yes, sir.
And I just don't want to sit here all day long hammering this thing out, and then 2 or 3 years from now, well, that didn't work, so we're at one.
Well, you know, I'll tell you this, Counselor, I don't know about all the projects that crashed. I don't think I was involved with them. But we have, you know, I'm not going to bring you an idea that doesn't have already the systems in place and the groundwork to make it a success. I'm not in this business to have half-brained ideas that are half-resourced and ultimately fail and get high-centered. I'm in this business to have success, and that means having success for our docs and having success for our patients. I'm with you. You know, if I'd had a big pot of money, you know, the first thing I would have done is, you know, here's an increase in the base salary. But I will say this, and I know that that's attractive, and I do think that it's needed. But any change in compensation that we do that does not utilize positive incentives for service is going to result in no more patients being served. And it's not a knock on the doctors, it's not a knock on the system, it is just fundamentals of human nature.
I think it's important also to look at, you know, when I first came into this job, the chief was very passionate. What do we need to do to improve access to our patients, get more patients seen? And it didn't take long to tour the clinics as they were in 2012 and 13 and see they were physically limited by space as the doc spoke to. And so you guys, the chief and you guys have put a lot of money into expansion and new facilities. We've added 100 new positions in the last year. And some of the vacancies we have in providers right now, I think 3 or 4 of those are actual new positions. So we've added staff, we've added more docs and providers. The other thing we heard was this electronic health record, you've got to do something. I mean, it was going down in the middle of visits. We could not function. We were at a status quo. We would not be seeing the number we are now under the RPMS system. It just would not do it. And we don't like it, but it's a tool that is absolutely essential to the way we do business now. And so this was the selection made by the group. We read every day where the other options, people are bailing out of that, changing, and nobody's happy with the electronic health record. This is the one we got. This is the one we felt like we could afford and provide what we needed. And I don't know if there is a perfect one out there, but we're making, the docs have done incredibly well transitioning, but now I think this is the next step to improving the access.
Well, my question, and I just want to make this very clear, that I want to see our providers paid what these smaller tribes are paying their providers.
Absolutely.
To steal them away from us. And we shouldn't be sitting here as a large tribe we are, and the money that we're making, and not paying these people what they deserve.
Yes, sir, absolutely. We agree.
And that's my whole point right there. I want our employees to be paid. That's all I have.
Councilor Byrd?
Yes, we have a shortage of docs across the state, and that creates competition for these docs, you know, from a private sector there. So I want to thank the committee for making these recommendations. We've been dealing with health care to improve health care for many, many years. When you're a tribe as large as we are, I was chairman of the health committee back in 1987 for 8 years. And we had the largest budget in the health, and we had the most employees. And with the increasing numbers of Cherokee that enroll in our tribe, probably 370,000 by now. We can argue whether Navajo's the largest or we're the largest, but it's good to hear that at least you're trying to keep up with the pace of health care for our patients. And that's the most important thing. My family comes from a rural area. They have to drive 25 miles to the nearest clinic. And they can't show up there and say they can't be seen. I mean, that's just unacceptable.
Mm-hmm.
And with us being the largest and most sophisticated tribe, with the revenue that we make, we can go to almost any department in the Cherokee Nation and we can boast that we're number one. Head Start, Career Services, Sequoia High School. We can go on and on and on. We come to the health. We still have work to do, but it's good to hear that you guys are trying to make some changes that will keep us up with the pace of not other tribes. We want to be number one in health care.
Yes, sir.
We just broke ground on the largest facility in the United States compared to anybody else out there. I'm trying to get excited about this, but it sounds like you guys are making some changes. But I'd like for Brian Hale and Dr. Grimm to give me the nod. Can we get excited about this, you guys? Because
we're very excited about it.
Good, because I've spent an enormous amount of time discussing health care with these two here. If they give me the nod, then I trust you guys are the experts. We appropriate the money for you to operate. But again, as the largest tribe, we should be able to solve these problems that we're dealing with.
Yes, sir.
So go ahead and keep us updated, and I commend you for the Health Compensation Committee for bringing these recommendations. So, Madam Chair, thank you.
Councilor Hatfield?
I commend you for being here today. I also, Speaker just said, thank you for saying a lot of the things that I was going to point out is from basically the inception of Cherokee Nation, as back in 60s, 70s till now, we've had tremendous growth, and it's growing every day. So number one, the growing pains, and we're trying to serve a large population. And I hear that those are the concerns of my constituents, which Mr. Baker and I serve 230,000 people, Mr. Baker. And health is the number one it's the number one issue. And I think it's the number one issue probably everywhere.
Yes, ma'am.
But here's the thing. All the research and all the work and all the development of this program you're presenting today, I'm not program, or I should say program, but did you work with an outside firm? Have you worked with a consulting firm that has expertise in healthcare programs, or is this your work?
So
I'm not criticizing.
No, it's fine. That's fine. So we have not actually worked with a consulting firm. Mm-hmm. What we did was draw from contracts that were being issued in the area and best practices. We spoke with a lot of folks at a lot of different health systems that deal with the compensation to ask questions about how they compensate their providers. What did the contracts look like? And a lot of it was spent, asking docs and even asking recruits, so what kind of contracts are you seeing out there? And universally, the response was they're RVU incentivized. So this is one of the things that kind of drove us. We don't want to if we're going to compete with other systems, we don't want to fail to embrace what is considered national standards. A de facto standard is when everybody does something and so it becomes a standard. Like there's no congressional law that says you have to, use RVUs. But when you look at, 9 out of 10 contracts in primary care containing RVU bonus structures, you start to think that, there probably is a tail risk or a risk that may happen down the road if we fail to kind of adopt that and embrace it.
And I probably along with the rest of the council members. I mean, I think you need to be compensated. And I also believe that work performance, you need bonus. That's just in any system. It just isn't in the health field. But at the same time, I think what today, it's the first time I've really heard
and anything about that, like, but I started out as a child at Hastings, was born there. And of course, I'm not in the system now, but at the same time, it's really enlightening to me. Of course, the majority of my family uses the system, so I get to hear, the concerns with them. So, but, I appreciate you being here. I appreciate you bringing it to, to our attention. And, but there are just many, many factors. And at the same time, I appreciate your hard work and
Thank you.
And getting this information to us. Thank you. Thank you.
Councilor Thornton.
Yes. I have to agree with Mr. Anglin over here on several different points. I feel that, of course, this is a government and a private funding. If we didn't have that government, we probably wouldn't be sitting here. And that's brought over the past years, this council has increased some salaries. It's been performing by doctors and providers. And it's probably been 4 or 5 years ago we increased some of their salaries. And what we was trying to do was hold them. But they're outgrowing us too damn fast. You want to get down to it. But I think one of the main things is what Bill brought up, and I think this was one of the things he was trying to get across, is that when you increase salaries in health, you not only need to do it for the doctors and providers, you need to bring in your maintenance, cleaning, security. All these people need an increase in salaries. And if you don't, you've got departments sitting there that they're going to be raising hell.
Mm-hmm.
And they may not serve our people as well as you would. And, they may be a throwback here on this. And if we don't include everybody and try to bring this health up to par, average, then let's bring it up to average for all our people. And us try to get above average out of these health folks to help our people, because that's what we're all in it for. They're all in it, you're in it, everybody here sitting at this table is in the same situation, and we want better service for our people. And to me, it doesn't make any difference. If we've got the money, we need to do it. And if I don't see where we don't have the funding if we want to go after the funding. And I think you all know that. But I didn't really see anything on the chart that was different between funding now and funding of what we need to bring this up to. And I'd like to see something on that, what the increase it would take to bring it up to where we want it, or where you want it, where you can work with it, where these people back here can work with it, where we can go out and hire new people in. And they want to come here because they receive funding, they receive benefits. And that's what I look at, and that's the way I feel about this thing. And I've been here a long time. I've seen this go a long ways in the last 18 years. And especially in the last 5, 6 years. We have grown, it's been ridiculous. Now, Osage seeing as many patients that we see, I don't think so. I can't see that, because we are so huge, we have so many people that need help, and we're living in a very, very poor environment in our districts. And these people have to have help. They don't have private insurance. And that's the ones I like to push and try to help. So thank you very much for coming and listening. And I hope that we can get something going within the next couple of months, because I would like to vote yay on this result.
And if I may make a comment to
Result.
that, the Human Resources Department, Nathan Morton, Anita Christie, Michelle Downing, and Alana Castile have been incredibly helpful in this, and we've worked looking at different ways to compensate the dogs, and they kept going back to the RVU structure even before we were able to do that, and so they are comfortable with this process, and hopefully Nathan's still here to talk about that. The other thing that they're doing, Human Resources, is they've been in a process of reevaluating every position. Well, I know at least in health they're working on it at different times to do a comp analysis to make sure our pay is where it is. We've made adjustments as those come up, and we're working toward getting our compensation for all staff to where it should be.
Well, it should be included in this
I-
package or what you're gonna put together.
Is that all?
Thank you.
Counselor Lay, before I let you go, I'm going to have to step out. I've got to go back to Stillwell to attend a funeral. So Counselor Warner, if you'd come take over the meeting, I'd appreciate that. Counselor Lay, you're up.
Thank you, Madam Chair, and thank you again for calling the meeting. Appreciate it. I'd like to have the compensation docs come forward again, if I could. I've got a couple of questions.
Yes, sir.
for them. Thank you, Doc.
Just pass this around. This is an Osage contract that actually I had written up because I agreed with them. On the third page, you'll see what the base is. And I just, thank you all so much. We appreciate even being heard. Going back to what you said about the maintenance and the janitors and the front desk people, all of them have received a 2% increase, except for us. We are the only people that haven't in the last 4 or 5 years. We just want to make sure that that is known also. So that, okay, that's it.
One of the things that I heard from Dr. Stalkup, and you know, like you guys heard me say, I've seen this plan before without the RVUs 2 years ago. And of course, it didn't work as good as planned. What, you have the system in place that allows you the time to roll through 20 or 30, 40 patients a day?
No.
I didn't think so,
We don't
but
have additional nurses.
the institutional system, or the EHR, whatever we're calling it, does not allow you to do that. If you had a scribe following you, would that help or not? Or
Maybe.
It would be independent of different providers practice different ways. Although it wasn't stated here earlier, it was implied, and we had talked about that health administration also understands that there would have to be changes to the system. It's the system.
Sure.
Back, we had a contractor that come through, I won't name, but they were looking at why can't we see 18? Why can't you see the 18? And my question was, no, it should be, why am I not able to see more? Why is our goal just 18? It's a system problem. Larger systems outside of here, if they have a pool, they have more flexibility. If my front desk calls in, they have someone immediately there. They're not pulling someone to do that job. As it currently is, I don't have, and I don't want this to sound bad, I don't have control of all the variables that would allow me to function as efficiently as I would function within how I practice. And there's some variability between physicians and providers in how they practice. So if my nursing is under an entirely different structure, if there's a nursing shortage, then they pull one of my nurses. It's not part of my decision-making process for the day. It's just I show up, I don't have a nurse, she's been pulled to cover on another clinic, so I'm down a person. Those are the variables we'd have to work out, and it wasn't spoken, but that's implied that we would definitely, otherwise we would just become frustrated. As Dr. Stalkup pointed out, the RVU system it's the industry standard, and it was developed to give some, so that you were evaluating apples to apples across the board. You could have a pediatrician seeing 25 kiddos and a internal medicine 15, but it's the same amount of work at the end of the day. That was what the RVU system is. It's not, and I'm not trying to, he did a wonderful job explaining it, but it's not necessarily compensation or third-party pay or reimbursement. It's work, just relative work. It's how much you work. The concern that we have as providers is being able to see in the current system, and it'd be a growth. I mean, there's going to be growing pains with that. We're talking about just implementing that as a incentive program, not the base salary. To go to full compensation, you usually are given 2 to 3 years. If you just come out, you're given a guaranteed salary as you transition to RVUs, as you work up to enough patients to pay your overhead, to pay your staff. You don't just jump right out into it, because if you're brand new out of school, you might only see 8 or 10. So I don't want to assume, but there would have to be a period of time where that was transitioned in, and look for, without penalizing the providers, the inefficiencies that we point out that allow us to be successful and be able to earn our keep RVU-wise, if that answers your question.
And that's kind of where I thought we were at. And also with the Osage tribe, Dr. Tinker now is the director over there, and I've known him all my life. And if somebody were to sit down with Dr. Pat Tinker for 30 minutes and he'd offer you a job, I guarantee you'd think about it. And we've had folks think hard about it, and maybe at the last minute decide to stick with us. And we've lost one. Of course, that person was an Osage citizen like Dr. Tinker is, so we understand that. But if you've got, I don't know what I wanted to say, if you got a good salesman like Pat Tinker, you can get docs. They're also paying a lot more money than we're paying. I want that understood. And I don't know if they're using RVUs, and I guess I don't care. I'm a council person who people want care, and that's why most of us are here. In fact, that's probably why all of us are here. Thank you, and thank the admin, medical admin for coming today. Appreciate all of it.
Hey, Brian?
Counselor Austin?
Yes, a technical question before I move this on. I don't want to hold it up. This is a confidential between you and
Right.
Dr. Standing Bear. And
Chief Standing Bear.
Chief Standing Bear. It is a
I've turned them down, and they already know I'm not coming.
Okay.
And so Dr. Rumsey is the medical director over there, and he was actually at my clinic, and then he now runs that medical clinic. I'm not entertaining that anymore.
Understand. Is it, what I'm asking is, it's a confidential document that was offered to you from the chief of the Osage tribe.
Right.
Has he given his blessing for this to be a public document?
Dr. Rumsey has, and Scott Johnson has, and Scott Johnson is the one that actually wrote it.
Okay.
And Dr. Rumsey and I are close friends, and he knew that we were coming here today.
I don't think it's a matter of in this room.
Right. Oh, no, I haven't shown it to anybody other than
It is a confidential
I understand
document, because
that.
it's not marked such, but it appeared to me like
No,
it
it's
should
a
be.
contract, I understand
It
that.
should be stated that it was a confidential document.
It is, and it's mine, and it's personal, and so it's not going to leave
Right.
other than with me today.
No
Thank you
picture
for that.
taking.
No picture taking, please. And the Cherokee Nation does see a lot more patients than the Osage. I met per provider per day in the clinic. It's probably not any more than what we're seeing, not 30 or 40 or.
Winding this down, we're going to get Counselor Thornton next.
You're talking about per day, per provider, and that type of thing. And you've mentioned numbers. You say 8, 10, 12, 22 of our people that you see. Well, has anybody out there come up with a number of people that are sitting there and didn't get to see a provider or nurse? How many people sitting there hadn't been counted within this system that called in and didn't get to come in? How many people out there, in other words, how long a waiting line would you have there if everybody come in to see a provider? And would it be back out, towards the parking lot? Would it be down towards my area where it'd be out in South somewhere? And you want to say that, your goal is to see everybody. And I'd like to know a number of who's not getting seen. And that basically would be a good number if y'all could come up with it. Now, I've got one more thing to say, and I want to retain you more, but you say that the people that aren't doctors or providers receive 2% raise a year in the last 3 or 4 or 5 years. But folks, you had checked into it. What is the national average for those people? And also the state average for those people and the private average for those people? Are we paying them way below average? Are we paying them too much by giving them 2% raise? I'd like to know where that's at also. So thank you very much again for coming, and appreciate you very much.
You too. Huh? You too. Yeah. Okay, anybody else? We wrap it up? I'd like to thank everybody for coming, and we'll stay in touch, and we hope we can work this thing out. So, council members, thank you. Thank you. So we will call this meeting adjourned. Some of you council